Okay, this starts the first in our series of EKG interpretations. So we're going to talk about the sinus rhythms first. Now, as we've talked about in class, this is the sheet that I'd like you to have either beside you, pulled up on your computer screen, or you have written down these 9 steps here. And then, of course, we will go over the treatment pieces as we talk about each of the dysrhythmias. So these first through 9 stages, this will help you in a systematic way determine what the underlying EKG rhythm is. So very important you have that. So the first rhythm that we'll see, and while in ICU, this might not be the most common rhythm, it may turn out to be, but outside the intensive care areas, this is probably one of the most common rhythms that you'll see, and that's normal sinus rhythm. You'll notice that there's 5 elements up top. There's not 9 like we had on the previous slide, but these 5 elements are the basic elements you need to determine what the basic underlying rhythm may be. The first thing we're going to look at is the rhythm regularity. So again, always start from the left side of the paper and move to the right side of the paper. Always want to do that. If you'll take your calipers and go from one R wave to the next R wave, and again, this first complex here, when determining rhythm regularity, I would include this. But when it comes to looking at the individual complexes, you'll note that you can't see the P wave or the P interval, so I wouldn't include that here. Also, on the top of this, there are no hash marks, but on your exams, this will denote a 6-second strip. Okay? So to determine regularity, put your calipers between the 2 R waves and march them across the paper from the left to the entire right side of the paper. And what you'll notice is it's very regular. It is not uncommon by the time that you end up here that you might be off by just 1 small box. That's very common. It's not a perfect world, but that would be a very regular rhythm. The second thing we'll look at is the rate. And again, since this is a regular rhythm, we have to calculate the heart rate. We'll calculate how many big boxes or small boxes are between 2 of the R waves. I always like to start with an R wave that falls on the dark hash mark or the dark lines here. And you can see that there's 1, 2, 3, about 3.5 big boxes, or that would be about 17 to 18 small boxes. 3.5 big boxes, 300 divided by 3.5 gives you about the lower 60s beats per minute. Then the next thing we're going to look at is your P wave. You always want to start with the first P wave you can see, and that's with this complex here. Your P wave is upright. It looks normal. It's not peaked, and it's prior to the QRS. Looks fine. Go to the very next one and compare it all the way across the strip. And we'll notice here there's 1 P wave for every QRS. It's upright. It's not peaked. And it does occur before the QRS, and everything is normal there. The next thing is the PR interval. We're going to measure from where the P wave comes off the isoelectric line to where the QRS comes off the isoelectric line, and that's basically from here to here. Again, when you measure that, pick your calipers up, move them to an area of the paper where there's no complexes because it's easier to count, and you'll notice that the PR interval is somewhere between 4 and 5 small boxes. We all measure things a small bit different. It's okay if someone gets 4 small boxes and you might get 5. So the PR interval here, I would say, is 4 small boxes and 0.16 seconds. Moving on to the QRS. When you're measuring the QRS, you measure where the QRS comes off the isoelectric line, and that's right here, to where the QRS would have or does go back to the isoelectric line had the ST segment allowed it. What I mean by this is you can clearly see how this ST segment is depressed off the isoelectric line. Because of that, it is not allowing that QRS to come back to the isoelectric line like it wants to. So in that case where the ST segment is involved, you have to guesstimate and tell me where that QRS would come back to the isoelectric line had it been allowed to do so. So there is a bit of guesstimate here. I would measure from here to approximately here. So we're looking at 1 to 2 small boxes. So 0.04 to 0.08, relatively normal. The next thing we're going to look at, again, is the T wave, although that's not up here. The T wave is here. It's after the QRS. It's not peaked, and it's not inverted. Then when you go back to look at the anomalies for this particular strip, again, we notice that our ST segment is depressed. It's depressed anywhere from 2 to 3 millimeters, but it is clinically significant. So the only abnormality that I find on this strip is your ST segment depression. But trying to determine the underlying rhythm, that's when you determine these 5 basic elements. This, having none of these being abnormal or irregular, means that this strip is a normal sinus rhythm with an ST segment depression. Treatment. With this treatment, the only treatment I would say is because we have ST segment involvement, then we might show a myocardium that's a bit stressed. So oxygen might be called for. So the treatment here would be O2 and continue to monitor. Moving down to this strip, this is also normal sinus. And again, this is about a 4-second strip. Don't worry about that. I won't give you this on the exam. I just want to show you, again, looking at regularity. This is very, very regular all the way across. We have a P wave that is exactly the same all the way across before the QRS, and it is upright. It is not peaked. I can measure my PR interval. It's about 4 small boxes, so very normal. I can measure my QRS. The ST segment here is slightly involved. Clinicians would say that's about a 1 millimeter depression, which it can be clinically significant if there's other things showing that the heart is otherwise stressed. But it still needs to be reported as a potential depression. But our QRS is about 2 boxes, so 0.08. Our T wave is present, and it's certainly not peaked, and it's upright. So the only abnormality here is a slight ST segment depression. If you calculate the heart rate, again, we're looking at about 3.5 little boxes, maybe 3 3/4. So we're looking at the low 60s. This is normal sinus rhythm with a slightly depressed ST segment. Treatment, again, same as up here. Potential oxygen therapy and continue to monitor. So again, that's one of the most common cardiac rhythms. Probably won't be on every single one of your ICU patients, but you will see it. So one of the more common cardiac dysrhythmias is sinus bradycardia. The only difference between the underlying baseline rhythm between normal sinus and sinus bradycardia is the fact that with sinus bradycardia, the rate is below 60. That's the only difference. Now, you can have other anomalies, as in this one, we clearly see that the ST segment is involved, okay? So when we look at sinus bradycardia, again, starting at the left, put your calipers between the R waves, and you'll notice that all the way across, it's very regular. Then calculating the heart rate. We've got 1, 2, 3, 4, 5, 6, 7, 8, about 8.5 little boxes. If you divide that into 300, you're going to see that the heart rate is somewhere in the 30s. So clearly below 60. If I look at my P wave, there's upright before the QRS, and there's 1 for every QRS. Very normal. My PR interval is about 4 boxes. I measure from here to here. So we're looking at 4 small boxes. 4 times 0.04 is 0.16, very much within the normal limits. I look at my QRS. Remember, I have ST segment involvement. So when my S wave comes back up, I've got to pick it back up to about here, because if the ST segment were normal or not involved, that's where my QRS would end. So my QRS here is about 1.5 boxes, so about 0.06 seconds, very normal. I do have ST segment depression, so make sure you make note of that so you don't forget it. I'm looking at my T wave, certainly not peaked. It's after my QRS and it's upright, so very normal. So the diagnosis on this is sinus bradycardia with ST segment depression. Now here's where the treatment gets a little different. With sinus bradycardia, as you all have learned since your first semester of nursing school, if a patient is symptomatic with bradycardia, then we're going to have to treat it. If they're asymptomatic, most likely we're not going to treat it. So when it comes to answering this on the exam, for the treatment, you have to give me 2 separate entities. With symptoms or symptomatic, however you want to word it, you would give atropine and continue to monitor. And with this slide, you would also say oxygen because of the depressed ST segment. The other avenue is asymptomatic or without symptoms. You would continue to monitor and denote that we have oxygen therapy because of the depressed ST segment. So that's sinus bradycardia, a relatively common one that you'll see within the intensive care unit. Sinus tachycardia is the flip side of that, or the other reverse. The only difference between normal sinus rhythm and sinus tachycardia is the heart rate. Again, with sinus tachycardia, the heart rate's going to be between 101 and approximately 150. Most of your textbooks, most of your clinicians will cut the heart rate off at 150 and call it sinus tachycardia. The reason being, with the treatment modalities, if the patient has a myocardium that's involved, recent MI or an evolving MI, heart failure, especially exacerbating heart failure, and specifically with congestive heart failure, because you know heart failure is not necessarily congestive. If the heart rate goes above 100, that can spell a deterioration in that type of patient. So we may want to treat this and slow the heart rate down. If the heart is not involved, then we may not choose any kind of treatment, because this type of scenario can happen to any person at any given time. Some of the more common reasons why sinus tachycardia occurs is anxiety, fever, exercise, learning that you have an exam, a pop quiz, your boyfriend just broke up with you, whatever it is, multiple reasons that sinus tachycardia can occur. Doesn't necessarily mean we're going to treat it, okay? So when we look at diagnosing this particular strip, again, go with the regularity first. Always start at the left side. When we look at regularity, if you march it all the way across, you'll notice it's very regular. Again, we're going to count, there's about 2 big boxes in between 2 R waves. 300 divided by 2 is clearly 150, so this is right at 150. We're going to find the P wave. Now here's where it gets a little interesting. The faster the heart rate, the more the EKG literally squeezes together, and the complexes have nowhere to go but into each other. The P wave, as you notice here, will start to walk itself up the downstroke of the T wave. That's a very common thing you see with sinus tachycardia. The faster the heart rate goes, in other words, when it goes above 150, specifically closer to 200 or more, you may actually see that P wave disappear. It's still there, it's just buried in that T wave, which is always bigger, so you can't count on it, you can't see it. That's where it gets a little harder to diagnose. But here we can clearly see that there's a P wave. So we start at the left and we notice it's not peaked. It makes it a little more difficult to see because you've got to kind of turn your calipers a little bit sideways to get the true measurement of the amplitude of that P wave. So you don't want to measure from here to here because that's not fair. It's picked that isoelectric line up because it's marching up inside the T wave. So that's about 2.5 millimeters, so borderline, but it's not peaked. But there is a P wave before every QRS, okay? Now, if you told me that P wave was peaked, wouldn't necessarily be wrong, all right? I can measure my PR interval. I put one side of my calipers here, the other side of my calipers here. Again, pick it up and move it to a place where there's no complexes. And I would say it's about 4 small boxes, so about 0.16 seconds. Then I'm going to look at my QRS. I'm going to measure from here to here. And that's about 2 to 3 small boxes, well within normal limits. I cannot determine if my ST segment is involved because the heart rate is too fast. We'd have to slow this heart rate down to really tell whether that ST segment is involved, okay? Now, it really is, and I can tell that by the bowing action here, but that's more of an advanced type of treatment, or advanced type of interpretation. I don't want to get you confused at this point. The next thing I'm going to look at is my T wave. My T wave is absolutely peaked. It's about 1.5 big boxes. And remember, a peaked T wave generally denotes hyperkalemia, okay? So right now, the only abnormality to the underlying rhythm is the fact that my heart rate is well above 100. So sinus tachycardia is what my underlying heart rate is. So I would say ST with peaked T waves. You can say with peaked P waves as well. I'd be okay if you said it with this rhythm, but technically it really doesn't have peaked P wave. So the treatment, again, we could give a calcium channel blocker, we could give a beta blocker. If we wanted them to relax, we could do breathing techniques, we could have them do a Valsalva maneuver. You can make some visitors leave the room that may be making the patient anxious. You can turn the lights off in the room, maybe turn the TV off, maybe turn the TV on. Or music therapy, whatever it may be, multiple things to get this heart rate down without using pharmacological agents. But if you want to use pharmacological agents, you're likely to see calcium channel blockers, beta blockers, etc. Okay? So that's going to end this particular slideshow talking about normal sinus rhythm, sinus bradycardia, and sinus tachycardia and their treatment modalities.